Good afternoon. It's always difficult having the after lunch session, but hopefully a bit of air in the room. I've got a few scenarios as well, so hopefully keep you interactive. I feel like a bit of an imposter talking about inherited arrhythmia conditions in a cardiomyopathy conference, but there are very common themes from the talks you've had already in my presentation and in the landscape of inherited arrhythmia. So this National Service Framework is 20 years old now. So this is the framework that suggested that those that have experienced a sudden death in a family relative under the age of 40 should be referred to an inherited cardiac centre for further evaluation, with the objective of trying to identify family members who may also be at risk of having a sudden arrhythmic death. So I'll just brief overview. The inherited arrhythmias, morphologically normal hearts at the macroscopic level, but at the molecular level, disturbances in the way electricity is conducted within cells and calcium handling. These are resting or provocable ECG traits that I'm going to talk about. And it's the pharmacological provocation that's associated with some potential inaccuracies. In general terms, as an overview, the genetic yields can range from, I've put 20%, but probably less than that, up to 75%, depending on which condition we're talking about. So if you want to have a quick overview of the diagnostic yields in SADS, which I'm going to focus my main talk on, looking at some of the historic studies, the original Amsterdam study by Hanno Tan in 2005, and the study by Elijah Baer in 2008, you can see that the yield is in excess of 40 to 50%. Now, that's largely based on the use of provocation agents such as adrenaline for the diagnosis of Brugada syndrome. And then you look at the more recent studies by McCorrigan or Van der Werf, in which sodium channel provocation was used at the discretion of the clinician. You also see differences in yield depending on whether or not a post-mortem was actually available for the subjects. In the Baer study, 100% of the cohort had a post-mortem and a morphologically normal heart, and that reduces down to 50% in Van der Werf study. And it's really important to understand that, because that's a huge area for variance in outcomes and yields. So what's the approach? How do we assess families in SADS? What's the best approach? Well, it's a difficult question because there's no best approach, but what is the approach that we take? The approach I think we take in our centre is to start by looking at the post-mortem. I think that's the most valuable tool that you have to determine how deep you're going to screen individuals and what you're going to use. The mode of death, was it in sleep or during exercise? Medical background of the deceased. Was there a history of syncope, any previous ECGs that we can look at? Were there any presence of any drugs, illicit drugs or prescription drugs? Were there any drugs that may have been associated with a condition such as long QT syndrome or Brugada syndrome? Was the post-mortem looked at by a cardiac pathologist? Was there a macroscopic and microscopic assessment of the tissue? And was there any DNA stored for future genetic evaluation? A detailed pedigree. I'm very lucky to have two really good ICC nurses who take a really detailed pedigree before we actually even see the patient. But is this a case of a sporadic sudden death, or are there a multiple number of deaths across the pedigree that we actually feel gives us a greater sense that this may be a genetic condition? And again, looking at the pedigree in terms of not just sudden death, but other associated conditions, conduction disease, early heart block, stroke, muscle weakness. These things may give us a sense that actually there is something going on here that may actually be associated with the sudden death that we're experiencing. Suspicious drowning, unexplained road traffic accidents. These are subtle but sensitive markers that there may be something going on. And then once we get the relative for assessment, generally speaking, sticking to first-degree relatives, looking at any relevant symptoms, seizures, syncope, before moving on to deep phenotyping. And I've called it deep phenotyping because in general terms, we throw a battery of tests at them. The most useful test probably is the resting 12-lead ECG. It's the most sensitive, reproducible test that's got a great amount of data attached to it in terms of sensitivity and specificity. The deeper you go, you lose your specificity. You may increase your sensitivity, but you will lose your specificity. So it's really important to consider these initial investigations first. And then, when should I consider sodium channel provocation? So for those of you in the audience that aren't familiar with sodium channel provocation, this is used primarily to look for Brugada syndrome. So Brugada syndrome is one of the leading causes of SADS that we see, and you saw that from the initial graph or table that I showed previously. When should I consider it? And it's really important to consider that, because depending on what cohort you look at, what sodium channel drug you use, the yields vary considerably. So if you look at this study by Hasdemir in 2015, where he subjective healthy controls to adrenaline provocation, he saw a yield of 4.5%. He saw a yield of nearly 30% in people that had a benign SVT, so a benign arrhythmia. You can have a positive adrenaline. So the drug itself, sodium channel provocation itself, is not perfect. In fact, it's extremely imperfect. We had a look at this. Ourselves, and in 100 healthy controls who underwent first pass ECG, echo, cardiac MRI to determine they were actually healthy with no family history, we found a yield of 3%. So in 3% of healthy white Caucasian individuals, we found we could produce a Brugada ECG pattern with adrenaline. So the test is not perfect. And as a result, the diagnosis of Brugada syndrome has been downgraded from being just a drug-induced ECG pattern to one that requires additional clinical or genetic features before you can fulfill the diagnostic criteria for Brugada syndrome. So going back to that question, when should I consider sodium channel provocation? So you've got an individual that's died suddenly. I've already mentioned you go through a stepwise process with initial phenotyping, 12-lead ECG, high-lead ECG, and echocardiography, exercise stress ECG to exclude alternative conditions such as CPVT or long QT. Is the resting ECG indicative of Brugada syndrome with a type 2, type 3 pattern? Then one could consider sodium channel provocation. In the absence of that, because in general terms that's generally quite rare to see a relative with a type 2 pattern in a SADS clinic, does the mode of death fit with one that could be assigned with Brugada syndrome? Was there death in sleep, or was it during exercise? Were there any provocable factors such as a fever or drugs that might potentiate Brugada syndrome? And if that is the case, then yes, sodium channel provocation might be indicated. I'll start with scenario 1 to highlight some of this. So this is a 26-year-old male, previously well, no cardiac symptoms, found deceased, dead in his bed, was drinking some alcohol the previous evening, but you can see from his blood alcohol level, it was negligible by the time he had his post-mortem. The heart was morphologically normal, sent to a cardiac pathologist, completely normal heart post-mortem. Parents and brother attend for screening. This is the father's high right precordial ECG. All his other investigations were normal. Should we consider sodium channel provocation? Hands up for yes. Hands up for no. Hands up for undecided. Most of you undecided. Okay, so looking at his 12-lead ECG in high lead, it's actually normal. So the confusing element that you get is this incomplete right bundle branch block pattern, which is very common. It's very sharp, it's benign, it doesn't mean anything really in the context of what we've heard so far. How the challenge we have is this notion that the incomplete right bundle branch block pattern, people hang on to it and think, oh, that must be Brugada syndrome. There are key differences between the incomplete right bundle branch block pattern and the type 2 pattern that we see in Brugada syndrome, and it all relates to the sharpness of that R prime. For those that aren't familiar with ECGs, what I'm highlighting here, the B is the R prime, and the sharpness of that measure on the ECG is associated with the likelihood that this might be a positive adrenaline test and actually be indicative of Brugada syndrome. So you can see This angle here is very broad, and that's much more likely to be associated with Brugada syndrome, whereas here it's very sharp and less likely. So going back to the father's ECG, it's very, very sharp, very normal ECG. In contrast, this is someone else's ECG that's very broad, has left axis deviation, very suspicious ECG, suggestive of potential Brugada syndrome. But going back to that question, should we consider sodium channel provocation in this gentleman? I've already said if his ECG is generally normal and the sudden death is indicative of Brugada syndrome, then it might be appropriate to do that. It's pragmatic. In my approach, the idea is not to suggest that sodium channel provocation is mandatory. It's an offer. You can tell them, look, all your tests are normal. We don't know why your son died. There is a chance that it could be Brugada syndrome. The death was suspicious of it. All of your ECG and investigations thus far haven't picked up anything. We do have a test. It's imperfect. 3% of healthy people can unfortunately develop this. What's the impact to that individual if they have a positive adrenaline versus if they don't have a positive, don't even undergo sodium channel provocation? So it's really difficult. You have to counsel your patients really specifically to tell them the risks and benefits of having the provocation test. So second scenario, 16-year-old female, sudden death during sports day, witness collapse whilst running, unsuccessful resuscitation. One prior history of collapse 12 months previously, felt to be related to the onset of menses in a heavy period. DNA is stored. So parents attend for screening. The parents are related, share a great-grandmother, but there is no other family member who has any sudden death at all in the family. Interestingly, the mother has a 3-year history of palpitations with a known high ventricular ectopic burden, which I've shown you on this 12-lead ECG. Here, these are ectopics, so very close to the T wave. These are very malignant-looking ectopics. So we've got a mother that's got some form of electrical problem with a morphologically normal heart whose daughter's now sadly passed away. What would be your next step? Further tests, look at the DNA that's been stored, subject the mother to a genetic test. What do you think? Mother has a genetic test or DNA stored in the deceased? Who goes for mother? Mother? Who goes for DNA that's stored? DNA that's stored. Okay, we did both in tandem. So the mother had an R138 panel because it was much quicker and logistically easier to consent her in clinic for a genetic test. In tandem, we can do the same in the daughter. So we found she had an SCM5A related cardiac arrhythmia, which is associated with this condition, this multiple ectopics coming from the Purkinje fibers, which causes ventricular arrhythmias and fatal sudden death, and was also found in the daughter. Finally, final scenario, 12-year-old male, sudden death, found by the bedside by his mother, no previous symptoms at all, negative post-mortem. Molecular autopsy in this situation was done immediately at the point of the post-mortem and identified a pathogenic missense variant in RYR2, which was felt to be associated with CPVT. The mother was also found to have the variant. This is her resting ECG, completely normal. Her exercise test ECG, however, was very malignant with bidirectional ventricular ectopics consistent with CPVT. So you can see how we've gone from that stepwise approach where we throw all the tests at people, then we have a question about should we be offering them adrenaline, to something that's a lot more focused and actually gives us a greater answer in terms of the clinical question. Why did this person die? Who's at risk? What can we do to treat people? We can treat this. So we found this is the gold standard, if you like, in terms of clinical screening in ICC, in inherited arrhythmia. So the molecular autopsy, which these two cases has underlined, allows us to determine potential causes of death following post-mortem evaluation. So next generation sequencing has allowed for this method to be implemented in SADS and does increase one's yield of clinical testing just based on clinical ECG testing in parallel with molecular testing. And a large Dutch study demonstrated a 40% yield when the two are used in parallel. And that's huge for these rare conditions. So it really relies on DNA being stored in the deceased. It really relies on the post-mortem understanding that, look, the morphologically normal heart, SADS panels, R138 panel, or going directly to, well, the post-mortem looked like arrhythmogenic cardiomyopathy, saving DNA, consenting, testing directly, rather than destroying the molecular material and us looking at the families in isolation some years later in some cases. So in summary, the stepwise evaluation, which I showed you before, less likely to result in false negatives, but a huge labor intensive, huge diagnostic intensive, and sometimes pharmacological provocation is inaccurate. It's costly and not always practical to have that approach. A focused approach based on the molecular autopsy, however, increases one's diagnostic yield, reduces the burden of clinical diagnostics, but relies on DNA storage at postmortem. So this is the schematic that was agreed by the ESC for the assessment of SADS families. And as you can see, there's a huge influence on the molecular autopsy. So a 2A criteria. So really enhances the ability to use molecular data to give us a diagnosis quickly and more succinctly than just systematic evaluation. However, we know that sometimes no autopsy is undertaken, so we have to revert back to familial evaluation in a stepwise fashion, excluding all things that you can before considering pharmacological provocation. Thank you.
Is that working? Thank you very much, Bode. It's a pleasure to introduce Georgiana, who's one of the specialist nurses working with me in Birmingham, who is the coordinator and lead for the sudden death pathway as well.
Thank you, David, and thank you to Dr. Bradlow and Cardiomyopathy UK for having me here this afternoon. So my name is Georgiana Neculau. I am one of the lead ICC nurses here in Birmingham, and I also lead on the NHS and coronial sudden unexpected death pathway in the West Midlands. So I'm here to talk to you about this pathway, give you a bit of an overview of when we started, what we achieved, and the direction in which we're going. So let's start, first of all, by setting up the problem. So what are we here to answer, essentially, and what are we here to resolve? We are attempting to help the families of those that have died suddenly. We know that every year in the UK, around about 750 people, young people, die each year. And in the grand scheme of things, it may not seem like a lot. Unexpected death only accounts for about 4% of these sudden cardiac deaths. However, if we are to put that into perspective, this is what 4% looks like. So we have 12 young people under the age of 35 who die every single week. So why did we need this pathway when we already had pockets of excellent practice in the country? Well, first and foremost, we know that ICCs are oftentimes silent. They don't really cause signs and symptoms in most of our patients until sudden unexpected deaths occur. We had no nationally agreed system to retain tissue for molecular autopsy and to identify those at risk. And we know that without tissue, we lose the only opportunity we have for genetic testing in the deceased individual, and we can't help those that we don't know they exist. So we do need those family members to be made known to us in order to help them. And overall, there was this inconsistent practice, which essentially led to a lot of missed opportunity in terms of retaining tissue and signposting those at risk to NHS ICC services. The pathway essentially had three main aims. The first one being to increase the number of family members assessed in a dedicated NHS ICC service, increase the tissue retention rate, and we did this by explaining the benefit of tissue retention to families and by making sure the pathologists do recognize the importance of this and routinely retain this tissue. And the last but not least, we wanted to improve the experience of the family members. And this was achieved by their prompt signposting to ICC clinics. It all began around about 2021 when a group of fantastic stakeholders got together and designed this pathway, which was then trialed for 2 years in all of the 7 GMSAs. So each had a representative which was linked to a coronial area and an ICC center. We followed the multi-agency models where we involved coroners, officers, pathologists, NHS ICC clinics, GLHs and charities. We delivered training to coroners and pathologists, and we ensured that we used a standardized referral and consenting process. And perhaps one of the most critical additions to this pathway was that we introduced this role. We called it an ICC coordinator. The role is essentially delivered by nurses or genetic counselors, and it acts almost like a linchpin, is the glue that keeps things going and connects the different agencies for the benefit of the family. And once the pilot phase ended, it was successful. I'm going to show you some figures after this. We began a controlled national expansion, and we are now in that stage. So how did this pathway, how did the person's family's journey look like before? Essentially, it started at the point of the coronal investigation, when the post-mortem was undertaken. The only problem was that tissue was not always retained. When it was retained, it wasn't always kept or made available to clinicians in a timely manner, and then it would later be destroyed because it wasn't utilized. Then the onus to seek a referral was left onto the bereaved family member. That wasn't always happening. Sometimes the family wasn't even aware they had to go and seek a referral. The GPs didn't always understand the purpose of the referral because there was no documentation of what had happened to the deceased. The post-mortem was oftentimes not made available to them. So it led to this year-long delay, essentially, from the time when the person would die to the time when the family was being assessed in a dedicated ICC clinic. And then, of course, we have these amazing genomic laboratory hubs, but without tissue, we can't really harness the power of genomics. So that opportunity was forever lost. So we try to improve that pathway a little bit. So the pathway, it continues to start with the coronal investigation, but what it does now, it enables the routine retention of splenic tissue. So we want all our pathologists to be aware of the importance of retaining tissue and the importance of making that recommendation to the family that they have to seek screening in a dedicated ICC service. The care is now faster and is joined up together because we are bringing genetic testing and the counseling aspect sort of closer to the time of death in the family. We want to offer genetic testing on the DNA of the person that passed away as opposed to wait a couple of years down the line when the first family member develops symptoms. We are hoping to deliver a more targeted assessment of relatives, because we start screening with the first-degree relatives and only cascade as and when necessary. And overall, we have improved access to ICC services. Because we have the ICC coordinator role, they link in with the family and they make sure the family receives all the investigations and the follow-up review with a consultant in clinic in a timely manner, as opposed to years later. So the pilot phase was evaluated by an external evaluator, a company called Bright Purpose, and they've identified some key findings, which I have outlined here. The main one was that the pathway is effective. So these figures are a little bit outdated now. They relate to March, April 2024, when the pilot phase ended. But essentially, you can see the figures were quite positive. I would say now they are about 30% higher than what you see on the slide. They've also determined that the role of the ICC coordinator was essential to the smooth running of this pathway. And they've identified this because certain areas had a gap in coverage, and that led to a breakdown in services. They've interviewed almost all the families involved in the pathway at the time, and the families reported that they felt very well supported, and their response was excellent. It was determined cost-wise, it was quite labour light and cost-effective for the coroners. The main cost comes from the introduction of this role, the IC coordinator, and we also had a band for support admin staff that helped us. And the last sort of key finding was that there was an urgent need for stable funding. So we've relied on some partial NHS England funding and some partial charity funding, but this provision is not commissioned at the moment, so this is still a risk. So how does the national rollout look like locally, and what is the implementation process like? So we essentially approach the coroner, the senior coroner for the region. We want them to buy into this pathway and to accept to deliver it in their jurisdiction. So we have an engagement meeting with them. Providing they agree, we then meet with their team, with their coroner officers. We deliver a bespoke training session to them, where we inform them of their roles and responsibilities. We disseminate all sorts of documentations with them to help make their lives easier and to ensure the referral process is as smooth as possible. And then we also meet with the pathologists, again, just making sure everyone is on the same page and aware of their responsibilities. Once we have completed these three elements, the site is technically considered live, and we begin to receive referrals from them. So I've made here sort of a long list of challenges. I try to come up with a solution for all of them. Perhaps in the interest of time, I'll just focus on the main ones. One of the main ones is there are some engagement delays, understandably, from the senior coroners. So not everyone is not willing. Most people are willing, but there are other competing projects, and there are other elements that we have to consider. So we have to approach senior coroners with a lot of tact and persistence to get them to buy into this. There are some workload pressures which come from managing the ongoing cases which have already been referred. At the same time, we have to manage the setting up of new sites. So that creates a little bit of a challenge sometimes. And there is also increased pressure on ICC clinics. The more visible we make ourselves, the more referral we get. And there is now these expectations that we have to see everyone rather quick. So this creates a pressure for each ICC service that's involved. And perhaps two of the other main challenges are the logistical and financial strains around sample transportations from the mortuary to the GLH. So this is very much work in progress, but we are trying to streamline this process. we want to make sure that each mortuary has RNA later fluid kits available so they can safely save that sample and send it to the GLH. And the last challenge is that there is still a lot of uncertainty around the long-term funding of this project. And to end on a positive note, I wanted to give you an overall sort of bird's eye view of the national picture. There are 71 coroners in England, and about 2/3 have already been approached, and a third of them have agreed to adopt the pathway. So this is very much progress that has been done in the last 12 months by myself and the other IC coordinators. Of course, it was a coordinated effort, and the fact that the others haven't been approached is mainly due to the fact that we still have quite a few vacancies that we need to fill. Overall, we're very hopeful that the project is successful, and we're hoping that it will be extended. Thank you.
Don't try that one.
Go on then. That's probably better. Thank you, Bode and Georgiana, for the fantastic presentations. We'll open up the questions to the floor.
Hello. Yeah. Thanks, Georgiana. That was great presentation and nice update. Just wondering why some of the coroners don't want to use the pathway, because this is like standard procedure, isn't it? There are RCP guidelines, Kennedy protocol and everything, where they already are meant to collect the samples. So what additional steps do they need to do? Why are things being blocked? That just puzzles me.
So it's actually quite labor light for the coroners. We're not really introducing that many changes. It should be part of their standard processes to a large extent. However, they do have a lot of other sort of competing projects, and they're extremely overworked and short-staffed. So those were the two main issues that we've encountered when we had a refusal. We've not had a blanket no, but we've had try us again in 12 months. We might change our mind.
Yeah. And another thing, there's a new test directory indication for sudden unexpected deaths, R441, which is a much wider panel, obviously. And not only just the cardiac genes, it covers epilepsy genes, metabolic ones. And so how is that sort of, is this sort of duplication in one way, or are there certain groups of patients who go down this pathway, and how is it going in terms of coordinating with how this pathway is going? So
R441, I think it's mainly applied in sudden death in children, and we do link in with the SUDIG nurses. We don't tend to get those referrals as much in Birmingham because they tend to go to the SUDIG nurses. However, the SUDIG nurses will then refer the family onto us, and we'll pick them up in that way. So the referral doesn't come directly from the coroner, but we'll make it.
So you are getting referrals from SUDIG nurses?
We are getting them now in Birmingham, yes.
Okay, that's good to know. Thank you.
Yeah.
Sorry, this may sound like a really silly question, but Georgiana, how do these people who unfortunately have a sudden death get initially flagged to you?
So it's the coroner who flags them to us. They are the first entity to become aware of the death. They are notified of the death. They instruct the pathologist to undertake an autopsy. The pathologist will then feed back the results of the autopsy, and it's at that point that I'm contacted to say, this person died with this condition, this is the next of kin, can you approach them?
And are they doing that routinely, or are you aware of?
This is what this pilot is trying to do, to make them do that routinely, essentially. They do it in the pilot sites, yes, religiously, but in other sites, it's very much work in progress.
Okay, thank you.
Hi, can I ask you, how long is that process taking at the moment? Like, when are these patients going to arrive to our clinics?
Sorry, can you repeat the last part of
Yeah, how long is the process taking from the sudden death occurring to the family members arriving to the clinic?
So it can vary only because it takes quite a long time for the autopsy to be undertaken. So after the regular post-mortem is done, there will usually be a recommendation for specialist cardiac autopsy. So the heart will be sent away to an expert. Then the results will be fed back to the original pathologist. Then the pathologist will feed back the results to the coroner. So this entire process can take about 2 to 3 months, sometimes longer. At that point, the referral is made to me. Once the referral is made to an ICC coordinator, things happen fairly quickly after that. I would say within about a month or so, the family will have some form of tests initiated.
Yeah, I think one of the challenges is how we see the family members quite quickly in clinic. We rely on, as a hospital, and obviously GP referrals from an income point of view to the hospital, but we almost have to bypass that in these cases. I just have a question for Bode. Bode, we heard in the session before lunch about the need for repeat screenings, 1 to 3 years, 3 to 5 years. What about in cases where the proband has long QT syndrome, for example? How often should we evaluate the family members, the children or the first-degree relatives, particularly if genetic testing is negative or genetic testing has not been performed in the proband? And also with SADS, is there ever a need for re-evaluation after the initial comprehensive investigation has been negative?
So the second part to that, generally, if you have a SADS family who you undertake initial stepwise comprehensive evaluation, I would, and you find nothing, I would generally say repeat ECG and echo alone in 3-5 years. I wouldn't suggest doing all of the tests. The ion channelopathies are provocable, so with a reasonably good sensitivity. So if you have a family of long QT, for example, and you subject one of their first-degree relatives to an exercise tolerance test, and it's normal, it's extremely reassuring if the proband's exercise tolerance test was abnormal. So it all goes back to the phenotype of the proband. If you're not seeing similar phenotypic evaluation in the relative, then I would be happy to say we've excluded that. But with the SADS families, yes, I would say repeat ECG and echo. One small caveat is if you undertake sodium channel provocation in adolescence, so before the age of 18, 16, there's a 25% false negative rate because of age-related penetration of Brugada syndrome. So in general terms, if you can avoid doing sodium channel provocation until they're 20, 21, you're less likely to have to do it twice.
And can I just ask also about something we see quite a lot, and really it's a heart sink moment, is the fever-induced Brugada ECG pattern. What do you do with these patients, and particularly what do you do for their first-degree relatives? Because that's always a challenge for us in clinic.
Again, that's been downgraded in terms of the diagnosis. So the Shanghai criteria, the graph, the table I showed at the initial part of the presentation, a spontaneous type 1 pattern for Brugada syndrome, absolutely, fundamentally diagnostic. Drug-induced, less so. Fever-induced, somewhere in between the two. So in the absence of any other clinical features such as a family history of sudden death or a positive genetic finding or another relative with a spontaneous type 1 pattern, then you're on a non-diagnostic element. So exploding that to test other relatives is actually quite dangerous. what we learned from the Israeli study where they focused on looking at all presentation with fever to an emergency department in Tel Aviv, they found 25% of people have the fever-induced type 1 pattern. So it's actually it's common. It's not necessarily associated with the malignant sudden death that we see. And actually, the same group looked at the prognosis, the long-term risk of those that had the fever, and the risk of sudden events was a lot lower.
Any other questions? Go on, Suresh. I've got one after you.
Sorry, it's a question for Bode. Thanks, Bode. We talk about Brugada and CPVTs a lot. Progressive cardiac conductive disease.
Yeah.
I don't seem to see many
The same
in
flavour,
the
no, you don't.
clinic. So is this because the phenotype is a bit non-specific, or are there not many around, or what's the missing link?
Yeah, so it's great. So good question. So I could talk about Brugada forever, as you know. But what you have in progressive cardiac conduction disease, it's a phenotype. It's not really a diagnosis. You should look for lamin. You should look for other cardiomyopathies. You should look for SCN5A related pathology. Is this just a part of that? Because with SCN5A, as you know, you get variable expressivity. So is this, and also in long QT, so long QT type 1 can cause conduction disease as well. In isolation, progressive conduction disease in isolation is actually relatively rare. That's why you don't see so much of it. Normally, it's part of another phenotype that you're just not seeing. You're not seeing the left ventricular dysfunction yet. You're not seeing the other features yet.
Certainly, there should be some families, isn't it, with younger onset, and I just
don't
always
see-
felt like
you-
we probably
yeah,
are
you don't
missing
see it.
some.
Yeah.
Thanks.
I might sneak one question myself, actually. Possibly to both of you. I'm just thinking back to the first talks this morning about harms and negative screening and things. And for all these families where we either don't have tissue for all the issues we've talked about, or where testing is negative, have you got a sense of how many people are coming through in terms of relatives where you do find something that's actionable then? And then maybe following on from that, what's the impact on people for, living with this uncertainty of there's been a sudden unexplained death that continues to be unexplained, I'm being screened. Are people reassured by that? Is it that they're actually terrified and, they still live with that uncertainty? What's the experience of managing those families?
Yeah, it's really difficult, as you say. So, historically, you will have a whole family, really emotionally charged, come up for testing because they've lost their sibling, their young son, and you tell them you can't find anything. So they have two unanswered questions, don't they? Or the parents have, why did my son or daughter pass away? And are my other children, are they at risk? And unfortunately, all you can say is, on the basis of the tests that we've done so far, we haven't found anything. This could have been one of those sporadic cases. I'm not certain that provides them the initial the reassurance that they want, and hence I think you're left with having to follow them up for that reason. I think you have to follow them up for that reason. I'm not in their situation. I can't say whether or not it provides them with reassurance coming along every year, but if you remember the reason they came to the clinic was something so profound, it might do.
Did you have a sense of how many people you might pick something up in?
Well, our yield's probably less than 20%, I would say.
In the pilot, of the around 300 first-degree relatives screened, they diagnosed about 30, so about 10%.
Is that without a GP, just first-degree screening?
Yes.
Yeah, and I suppose in one of the tables I put up of the yields from SADS, it's heavily linked to provocation. So the research I showed you on the false positives of adrenaline, there's a paradigm shift between how ICC doctors undertake sodium channel provocation with a lot more reservation now. So perhaps the yields in 2008 of 50%, we're not going to see that anymore.
Thank you. Any other questions?
Just a question for Bode. I came a little bit late after you speaking. At what age sort of would you stop screening?
It depends on what for SADS or
Yeah, for SADS.
For SADS, yeah, it's difficult. I suppose I would say once someone's getting, if the person that has died, if you go back to the service framework, which says 40, generally we say 35, but the service framework says 40. Once you're getting to 50s, you're less likely to find the condition that's associated with a greater risk of sudden death than hypertension, coronary artery disease. So at that point, I would say, look, focus on the environmental acquired cardiac conditions that are associated with sudden death rather than long QT or CPVT. I think that's unlikely. Remember I said if the tests are normal, I do recommend ECG and echo every 3 years. Again, why, I don't know, but maybe that's just because we are uncertain about the uncertain, what we don't know. So we tell them, look, come back, have an ECG and echo. But at some point, the balance of conditions favours managing their high blood pressure or their cholesterol. I suppose, 40, 50 is probably the cutoff based on what we know about the prevalence of sudden death, the prevalence of SADS based on age being 35 generally.
I was just wondering if you feel there's an argument to stop, that once you've done the full family and you've done all of the testing that you can, is it not an argument to stop testing and encourage them to continue life without the burden of that ongoing testing, especially if you're saying we've found nothing and then we're doing sort of ECGs and echoes 3 yearly, to what ends?
That's a great question. That's it, isn't it? So I suppose that echo at 3 yearly is to reassure us, not them, isn't it? So it's difficult. I suppose the landscape that we have, or potentially we have in the last few years, is patients do take ownership of their own medical problems. So if you tell them, look, if you're well and you're doing all the things that you would want to be doing and have no problems, then I'll leave it to you, open.
Sorry, I'm just thinking of a particular family, but is it not then putting the onus on them to decide to stop screening, and is that fair?
I suppose it's evidence-based, isn't it? So what we're saying is that the yield is vanishingly low the longer you are away from that baseline. So in some respect, it's not negligent to say, look, if you're well with no symptoms, you don't need anything. And that's the basis of that argument, isn't it?
Yeah, that's what I'm arguing. Why would you offer it if, in the first place?
Because in some conditions we do get some change, but not as you go on and on and on in terms of long-term follow-up. Long-term follow-up is associated with a reduced yield, yeah. So.
If there are no more questions, I think we can go for the next break. Thank you very much, Bode and Georgiana, for your lovely talks.